everyone, and welcome to This Explainer. As medical students and, soon-to-be doctors, you're going to encounter a vast and sometimes completely perplexing array of human experiences on the wards. So our goal today is highly practical. We want to equip you with the precise vocabulary and the diagnostic frameworks you need to accurately identify severe psychiatric symptoms. Basically, we're going to bridge that massive gap between abstract textbook theory and the actual, living, breathing patient sitting right in front of you.
So let me just ask you this right out of the gate. How can you really tell if your patient is experiencing a totally harmless trick of the mind or if they're in the very first subtle stages of severe psychosis? Seriously, think about that for a second. Because the stakes for your clinical diagnostic skills literally couldn't be higher. A simple misinterpretation here can drastically alter a patient's entire treatment path and, frankly, their whole life. Okay, here's our agenda for today, mapping out what we like to call the diagnostic funnel. First, we'll cover the foundations of perception. Second, illusions versus true hallucinations. Third, diagnosing perceptual symptoms. Fourth, defining clinical delusions. And fifth, key delusional themes. All right, let's dive right into section 1, the foundations of perception. Because before we can diagnose the abnormal, we really have to deeply understand our baseline. Notice the contrast here between a true perceptant and a mental image. Perception involves raw data coming from your sense organs that your cognitive processes then reassemble. And crucially, you cannot terminate a true perception just by trying really hard. If your eyes are open, you see what's there. Imagery, on the flip side, is generated entirely within the mind. It fundamentally lacks that true sense of reality, and a healthy person can call it up or turn it off entirely at will. The absolute cornerstone here is that healthy people can effortlessly tell the difference between the two. Now, there's a really fascinating overlap between these two things, called pareidolia. This is a highly tested clinical definition you absolutely need to lock into your brain. Pareidolia happens when mental imagery persists alongside a weak, unstructured, but very real percept. It's a specific little intersection where your mind's imagery actively combines with the physical world around you. And honestly, even doctors aren't immune to this. I mean, we've all seen a happy face in our morning coffee foam or looked at a washing machine and thought it looked, surprised. This is a completely normal, totally harmless phenomenon. It's simply your brain eagerly trying to extract a familiar pattern, like a human face, from random, unstructured sensory data. Moving right along to section 2, illusions versus true hallucinations. Let's see how normal perception can actually start to deviate into the realm of clinical pathology. So the crucial point here is figuring out the boundary between the benign and the pathological. Think about mistaking a bush in the dark for an attacker because you're feeling anxious. That's a classic illusion. It's a misperception of real external stimulus because the light is low, but it carries almost zero real diagnostic significance. A true hallucination, however, is completely different. It's a percept experienced in the absence of an external stimulus. It cannot be terminated at will, and it carries immense diagnostic value, pointing directly toward a psychiatric disorder. Let's detail this hallucinatory spectrum a bit more. We categorize them by their complexity and their sensory modality. So they can be elementary, like hearing simple bangs or seeing flashes of light, or they can be complex, like hearing distinct voices or seeing fully formed scenes. And these modalities span across all the senses. A tactile hallucination, which is sometimes called haptic, might involve the terrifying, vivid sensation of insects or worms burrowing just under the patient's skin. Now, this is where things get really wild. Notice the chilling phenomenon depicted here, the otoscopic hallucination. This is a super rare, highly specific disturbance where a patient actually sees their own body projected out into external space, usually right in front of them. Sometimes, this even comes with the chilling conviction that this visual projection is a doppelganger or an exact autonomous double of themselves. Okay, moving further down the funnel to section 3, diagnosing perceptual symptoms. Let's look at the so what for us as doctors and map these symptoms to actual disorders. This matrix right here is pure high-yield gold for your exams and ward rounds. Lock these takeaways in. Visual or otoscopic hallucinations strongly linked to underlying organic disorders. Think things like temporal lobe epilepsy or brain tumors. On the other hand, third-person auditory hallucinations, where voices talk about the patient, saying things like he is doing this or she is bad, point heavily to schizophrenia. Conversely, if you have second-person auditory voices that speak directly to the patient with derogatory content, literally telling them they're a failure, that strongly suggests a severe depressive disorder. You're also definitely going to encounter the term pseudo-hallucinations. These are sensory experiences that either don't seem to represent external reality, like they feel located inside the mind, or they appear external but feel fundamentally unreal. Like true hallucinations, patients can't just dismiss them with willpower. But here's the thing. Clinically, it's usually sufficient just to determine if a percept is a true hallucination or not, because it's the true hallucinations that carry the real, actionable diagnostic weight for us. Transitioning from sensory inputs to cognitive beliefs, we arrive at Section 4, Defining Clinical Delusions. This is where we encounter the true pathology of thought. You absolutely must know this definition verbatim. A delusion is a firmly held belief on inadequate grounds, not affected by rational argument or evidence to the contrary, and not a conventional belief expected of their cultural background. This is a cardinal symptom of psychosis, and remember, delusions dictate actions. Think of a man who firmly believes he's being irradiated by sonic waves, which leads him to literally barricade his door and cover his windows with silver foil. To him, that threat is absolute reality. We categorize these into primary and secondary. Let's compare them. A primary, or autochthonous delusion, appears completely suddenly, with full conviction and zero prior mental events leading up to it. Imagine a sudden, unshakable conviction of changing sex out of nowhere. A secondary delusion, however, is derived from a preceding morbid experience. It's the patient's attempt to explain what's happening to them. A profoundly depressed patient might develop a secondary delusion that they are utterly worthless to explain their rock-bottom mood. Or a patient hearing voices might logically deduce that they're being monitored by the government. Psychosis is rarely just a light switch flipping on. It's a progressive build. These distinct stages of delusion formation show exactly how a terrifying new reality slowly consolidates and hardens in the mind over time. Let's walk through this timeline. It very often starts with a delusional mood, or Wahnstimmung, which is this eerie, unexplainable feeling of foreboding that an unidentified, sinister event is coming. This then leads to delusional perception, where a completely normal object is suddenly given a profound, abnormal meaning, like a pen sitting on a desk is suddenly interpreted as a sign to die. And then you get delusional memory. This is where a delusional interpretation is attached to a past, completely genuine event. For example, a patient falsely remembering a perfectly normal episode of stomach flu vomiting from years ago and now suddenly interpreting it as an intentional poisoning attempt by their family. Finally, we've reached Section 5. Key delusional themes. Pay attention here, because the specific theme of a delusion is a massive clue pointing you right toward an accurate diagnosis. Here are the common themes you are absolutely going to encounter on the wards: persecutory, delusions of reference, grandiose, and bizarre. Persecutory is the classic belief of being harmed or plotted against. Delusions of reference involve a patient thinking entirely unconnected public events are directed personally at them. They might think a national TV news broadcast is speaking directly to them in some kind of coded message. And grandiose delusions involve immense wealth or power, which you'll very often see in mania. Think of puppet strings for a second. That perfectly represents passivity phenomena, or delusions of control. This is when a patient firmly believes that outside agencies and not their own free will are controlling their actions, their movements, or their impulses. They might feel entirely physically manipulated. Eliciting this symptom in your interview is critical because it strongly suggests schizophrenia. A related and honestly terrifying theme is the loss of possession of thought. We all take the privacy of our own minds totally for granted, right? Well, psychotic patients lose this conviction completely. This breaks down into 3 specific experiences. Thought insertion, where alien thoughts are actively implanted into their mind by outside forces. Thought withdrawal, where their thoughts are literally extracted or stolen from their head, which is often accompanied by a sudden, jarring blockage in their speech. And finally, thought broadcasting, which is the belief that their private internal thoughts are literally being broadcast out loud for everyone in the room to hear. As we wrap up this explainer, I want to leave all of you future clinicians with this one provocative question. If you observe a patient's perceptual disturbance, crossing that delicate boundary from a fleeting illusion into a fully systematized, unshakable delusion, how will your clinical approach to that patient change? How does knowing this alter your interview strategy, the way you show empathy, and your immediate medical interventions? Adapting your real-world practice based on these differential frameworks, that is the true art of clinical psychiatry. Thank you so much for learning with us today, and we'll see you next time.